Today's webinar, Hepatitis C Success, State-Level Advocacy Successes. My name is Ronnie Marks, and to give you a quick background, I am a patient who was diagnosed in 1996 when there was very little information. I then became an advocate and went on to facilitate a support group for 17 years and then founded an organization, the Hepatitis C Mentor Group. It's an organization that addresses the lack of supportive service for people living with hepatitis C and co-infection. We provide patients education on hepatitis C and co-infection, as well as resources to help access to medications, staying healthy, and dealing while waiting for treatment. The program provides resources and services nationwide to hospitals, clinics, other organizations, including substance use communities, and individuals wanting to establish or run educational patient support groups. Thank you for taking the time to participate today. We're new to NVHR. It is a national coalition of over 475 organizations working to fight and ultimately end the hepatitis C epidemics in the United States. I encourage you to visit the website, www.nvhr.org, and consider organization not already a member, or by signing up for our listserv as an individual. You can go to www.nvhr.org/join for more information. Before we begin the webinar today, I'd like to go over some housekeeping. This webinar is recorded. Slides from the presentations and the webinar recording will be made available to everyone who registered and will be on NVHR's website, again, www.nvhr.org. All lines are muted to eliminate background noise. You may submit questions at any time during the webinar using the function or by emailing Tina Broder, the NVHR program at tbroder@nvhr. I also, while I'm talking about Tina, want to thank her for organizing today's webinar. We will have a question and answer period following all of the presentations. Today we will hear from 3 advocates who have led successful efforts to expand hepatitis C treatment access in their state. They will share strategies, lessons learned, and advice for other advocates. I would like to personally thank panelists for their leadership and dedication to fighting discriminatory hepatitis C treatment restrictions, taking time today to share their experiences and thoughts. And just a personal note, I worked with all 3 of these advocates, and they all share a passion and an unrelentless drive that brings us, and lucky to have them with us. I'm going to start a biography now for each speaker before their presentation, and our first 2 speakers are Alexandra Sharif and Dr. Stacy Truskin, who will speak about their work in Pennsylvania. Alex is an amazing lady. I know her personally, and she's the viral hepatitis coordinator for the city of Philadelphia. She is also the founder and co-chair of the Hepatitis C Ally of Philadelphia, HepCap. Stacy Truskin is the director of viral hepatitis programs at Philadelphia Fight. She is also the community co-chair of HepCap. I am now turning it over to Alex and Stacy.
Thank you, Ronnie. Can you guys hear us? Just want to make sure we're not muted.
Yes.
Okay, cool. Yeah, thank you, Ronnie. We are huge fans of yours as well. So I can't think of anyone I'd rather have introduce us. And thanks for everyone listening in. So on this intro slide, what you see is a poster that is up in our metro stations in Philly. by our transportation authority, SEPTA. Their logo is "We're Getting There," which I think because their projects are always delayed and they're kind of notoriously a headache for people who take public transportation. I don't think we're as bad off as at HepCap, but we are getting there in the sense that we're making progress, but I think sometimes it's slower than we as advocates would like, and we often have unforeseen roadblocks come up and delay our efforts. But it was kind of a fitting picture to use on our opening slide. So as we get started, I thought it might be helpful to give a snapshot of what Hep C looks like in Pennsylvania. Go ahead and advance to the next slide. So, surveillance is notoriously limited across the country for hepatitis. So our estimates of who is affected are rough estimates in a lot of places, and we lack information like demographic information or risk factor information. Pennsylvania is more fortunate than other jurisdictions at the state level. There's some limited surveillance, but they've really done a great job, especially in the last year with some funding from ASTO to do a state epi profile. They've cleaned up their data a lot and have a much better understanding of what the epidemic looks like at a state level. And I think that ASTO grant has showed with a small infusion of resources, you can really improve the snapshot and create a meaningful document that we're hoping will really help with policy and awareness raising. It's going through editing right now, so it will be out soon. And at the local level in Philadelphia, where Stacy and I are based, we're really lucky that Philadelphia is one of 7 funded surveillance sites. We did get some bridge funding until the next surveillance funding announcement, which should come out next year, but we're still not sure if cities will continue to be funded under that grant. So we're kind of in a precarious situation, which is a shame because having the surveillance grant has really enhanced our knowledge of what Hep C looks like in Philadelphia. And I think that what we've learned is that data and having numbers and information about what Hep C looks like in your area is a really important tool for advocacy. And it can be used to really make the case for who we need to be treating and where the treatment gaps are. But on the other hand, I would also point out that on the flip side of that is I think that numbers and data can also be used to justify policies. Cases, the policies that we're fighting against, where I think states try to use the number of cases to justify why they put up treatment barriers. So surveillance could be a double-edged sword in that way. So the next couple slides show that much like in other places in the United States, the profile of Hep C is changing. So traditionally it was baby boomers that we talked about and that CDC has prioritized, but you can from 2003 to 2014 on the next slide, we've gone from having that baby boomer peak to 2 peaks where you have the baby boomers and you also have this new peak in young people who are using drugs. I think that Charlie, who has the hepatitis coordinator position in Pennsylvania, has done a really great job raising the profile of hepatitis in Pennsylvania, and a big way in which he's done that is tying Hep C to the opioid epidemic. We had a new administration come on last year, and they've really made the opioid issue a priority, and Charlie's really been great at making sure Hep C is a big part of those conversations around how we fight the opioid epidemic. The next slide shows the growing density of cases in young people across the state. And I think it's important to point out how much we've seen an increase among 15 to 35-year-olds because most of those people probably wouldn't be eligible for treatment under the current Medicaid fee-for-service treatment guidelines, which we'll get to in a moment. And then the next slide shows the overlap in hepatitis cases and drug treatment admissions. And I think that a point to make here is that one of the additional challenges we have in Pennsylvania is that the Department of Drug and Alcohol and the Department of Health are separate departments, separate state agencies. And so when we're talking about services and linkage to care, those aren't well integrated in our drug and alcohol treatment settings. So even without the Medicaid restrictions on treatment, we still have significant barriers that really slow down the process of getting people diagnosed and into care. And so I think this map shows that even though there's this overlap, often people aren't making it in a timely way from treatment to medical care for their hepatitis. The next couple of slides show some similar data from Philadelphia and our surveillance. So if you keep going, you can see, again, similar to the state level, similar to other places in the country, over time, we've seen the epidemic be an epidemic of baby boomers and move to affect this dual population of baby boomers and young injection drug users. Shows a few different graphs broken down by age, and it shows how the risk profile of hepatitis C has changed in different age cohorts. So if you keep advancing, there should be 2 more pie charts. Okay. And so something to be mindful of here is, one, the increase in drug as a risk factor, but also the younger populations. We're seeing growing numbers of people with Hep C who have reported a history of incarceration, which again is important to point out when we're talking about treatment access, because this is another area in which we see huge barriers to treatment. And Pennsylvania was in the spotlight just this last week because there was a lawsuit presented to the state for Mumia Abu-Jamal. He has been denied treatment, and while it didn't go through this time, I think they're going to be resubmitting their case, and the judge did call out Pennsylvania for basic institutional treatment of prisoners by withholding Hep C treatment. So it's important to be, I think, mindful of that population when we're talking about treatment access. It can be a different set of challenges from the Medicaid, but still one that we need to be working on. And then the next slide shows that how much work we have to do. Basically, because we have surveillance, we've been able to develop a local cascade, fairly similar, a little worse off than the national Hep C care continuum. And I think that what it shows, especially for folks in Medicaid who I think are afraid of this tidal wave of patients they're going to see asking for treatment and having these astronomical costs, we still have a lot of work to do moving people just from linkage from diagnosis into treatment. So I think that the number of people accessing treatment is going to be more gradual than they're often saying in public. I think one of their big fears that they express is the states can't afford this wave of treatment. And I think this shows that's not necessarily going to happen. So I'm going to let Stacy talk about where we are now with treatment access.
Okay. So in Pennsylvania, this really has been a work in progress. Currently, there is Act 87, which was just passed, I guess, about a month and a half ago now, which requires hepatitis C screening of physicians of the birth cohort. However, this mandate is unfunded, and there really is no way to track whether or not the mandate is being followed or to enforce it. But most importantly, and my biggest issue with a mandate of this kind, is that there's really no support and no education available for providers. I think it's really not helpful to mandate providers to do something that many may not have a complete understanding of how or why they should be doing it. And so that's something that we're going to kind of be working on to try to address and really make the most of this as more as an opportunity to try to educate our primary care colleagues. So in Pennsylvania, treatment is mostly happening in the specialty setting, hepatology, GI, and infectious disease providers. We're starting to see some primary care beginning to train for treatment. And then in Pennsylvania, there was an RFA put out for opioid centers of excellence that may actually end up expanding treatment if those centers try to co-locate hepatitis C care within them, which is something that there's been quite a bit of conversation about. And really, these opioid centers were intended to improve the integration of primary care and behavioral health into substance use treatment services. Next slide. So we know that the VA approves treatment for all veterans, irrespective of disease stage, irrespective of addiction history. Everybody gets access to care. In Pennsylvania, private insurers and Medicare, just like the rest of the country, we're seeing really wide-scale approval for individuals irrespective of disease stage. We still are seeing challenges in Pennsylvania fee-for-service and our Medicaid managed care where there's a significant disparity between approval rates, where we still have restrictions in place for many of those patients. Next slide. So we've seen quite an evolution over the last year and a half, and I think the next slide will detail some of that for us. So a lot of the evolution that we've seen has really, I'm proud to say, been a result of HEPCAP's activism in this area, and really our ability to kind of collaborate with other organizations around the state that have also had a vested interest, and just provide a beacon and a way to harness all of that energy. So our organization started in 2012, founded by Alex, who is here with me today, and has really grown to include over 400 partners that represent over 100 agencies and organizations. We have a co-leadership model where Alex is the local government chair and I am the community chair, and we really try to engage city agencies that serve individuals disproportionately affected by hepatitis C, community-based organization, harm reduction partners, clinicians, students. We do invite industry, but they are not invited to present. And of course, anyone affected by hepatitis C, both patients and their family members, loved ones, and friends. We meet every other month, and we basically use it to share information, get feedbacks on what's happening on the ground. We hold events that raise awareness. We disseminate education through our mailing lists, and most notably, we've been recently to kind of harness some rabble rousing and participate in a little more of activism rather than just advocacy. Next slide. So if you just kind of keep advancing, we have five medical centers from Philadelphia represented. We've got all different community-based organizations and government involved, and then of course industry. But this just gives you a sense of some of our community partners. We can't fit them all on one slide, but it's really a wide array of folks that come to our meetings, and we're really proud of that. Next slide. So we know that in 2013, a new treatment era started. We have a wave of new oral treatments which became available for treatment. There was a lot of excitement, but of course that was dampened by the price tag for the drug, which really was used as a way for payers to ration medication to only the sickest patients. And both clinicians and patients experience these barriers. They're discriminatory restrictions that are based on whether or not somebody has been drug and alcohol free for 6 months, really penalizing folks that have a comorbid condition of addiction, and really limiting treatment to specialists when there have been primary care providers that are really comfortable and well versed in treating chronic viral illnesses like HIV and hepatitis C. And then there was a requirement often for biopsies, which are invasive and many would consider no longer the standard of care, but also a need for a FibroScan, which until much more recently, and still very much in some places, is hard to get. and was difficult to have in order to qualify for treatment. We also know that the USPSTF gave a grade B recommendation to expand the HCV testing recommendations and really boosted an effort to expand screening and diagnosis. And so that compounded with this new cure that was available, which really had very minimal side effects, made it even more imperative to try to get folks tested and then linked to cure. So what we did was we first, over time, educated our HepCap members about treatment access and HCV-related policies. And of course, this was a moving target. Treatment restrictions in Pennsylvania, and I know in other parts of the country, are ever evolving, sometimes not as quickly as we would like, although also sometimes in ways that we don't want them to evolve, which seems like they're just being, payers are being obstructionist and trying to change things. So it's hard to keep up in real time. So we provided HepCap meetings as a way to have a forum to educate and disseminate information as close to real time as possible to our members. And then we joined forces with other advocates around the country and around the city and the state. So we built a statewide network of advocates working with our colleagues on the outside of the state with CLA, the Community Liver Alliance, and we co-branded our advocacy materials. And then also the NVHR Treatment Access Work Group, which really has allowed us to kind of keep our finger on the pulse of what's happening outside of Pennsylvania, and has just been really a wonderful place for us to be inspired and exchange ideas with our colleagues around the country.
So on the next slide, in 2015, we also had a great opportunity and a timely opportunity. So CDC offered Pennsylvania, Massachusetts, and Florida a chance to fund a state summit on hepatitis. And given the treatment restrictions, this was really a timely opportunity to engage with state leaders around the issue of hepatitis. We made it broad to focus on the entire care continuum. We had people from federal and state agencies who were invited, community-based partners, clinicians, people affected by hepatitis C, and we made sure that we made time both for the presentation of challenges and best practices, but also created space for dialogue and conversations between the different partners we were bringing together in the room. So on to the next slide. This was a really great opportunity to in the room and have a very strategic conversation around treatment access. So this was in May 2015. It was around the time when we were experiencing the more severe treatment restrictions. And the session on treatment was only an hour and 45 minutes. Was the result of weeks of preparation behind the scenes. It was a lot of strategy went into putting that 1 hour and 45 minutes together. So we had an overview of where we are with treatment. We had Robert Greenwald from the Harvard Center for Health Law and Policy Innovation come and talk about treatment restrictions, comparing Pennsylvania to Massachusetts as a state with less restrictions, and then offering examples of states that had more restrictions and saying that we were somewhere in the middle. Inviting him really fired up some folks at the state government level, and they were really afraid, I think, they were going to be bombarded with act. So we were really strategic in putting together a panel after Robert Greenwald, where both the state but also clinicians and a patient could share their experiences around treatment. We had a facilitator who's really good at keeping everything calm and civil and making it so it wasn't confrontational. And we prepped everyone in advance for what to expect and what talking points we wanted people to cover. And we also made our seating very strategic at this event too, where we mixed people at different tables so we could kind of try to stimulate some of the conversations we felt. So we had Robert Greenwald sitting at a table with the state Medicaid medical director so that they could kind of have a chance to talk one-on-one both before and after the treatment panel. So I think this is a real game changer, not just this specific session, but that day as a whole. So it was the first time something had really been held like this in the state to focus on hepatitis and get the state really thinking of talking about elimination and thinking about ending Hep C. So if you have an opportunity to convene partners and get everyone in the same room, it can provide a really powerful sense of energy. And so the next slide, I'll let Stacy talk about the kind of the first round of victory that we had in part as a result of, I think, that forum and some of the conversations from that.
Yeah, so not too far after the forum, we had a P&T meeting, which I was really grateful to have been selected to serve as a content expert in hepatitis B. And there were a lot of conversations with the Medicaid folks before that meeting to discuss how to best present the status quo of hepatitis C treatment, including some pricing information as well as cure rates and so on. And so that presentation was about 15 minutes long, and there was some conversation around treatment access as well, and recognizing that even in that moment we would have loved to have treatment access opened up to F0. The likelihood that that was going to happen was pretty slim. So we made some strategic decisions as to what to best advocate for, and we knew that as a first step we really wanted to eliminate the sobriety requirement, and we thought we could get some movement also towards lessened disease severity restrictions, and that F2 was perhaps the first step towards a real win of open access. And we also wanted to make sure that payers would not restrict medication if somebody did not have access to a fiber scan. So in much of the state where it's much more rural than it is in Philadelphia, we knew that fiber scans were very hard to come by. And so we also were able to edit the treatment restriction criteria to include FiberSure and other measures of disease severity, including provider examination. And we wanted to make sure that HIV and HCV co-infection was automatically approved irrespective of disease stage. And the P&T Committee did in fact agree to make those changes, and while we were very clear that this was only a first step towards the end goal, we were very pleased to have had some success. And at the time, Pennsylvania became a leader in this, and of course, since we've continued to work on it. Next slide.
So since 2015, we've continued to work with the state, and especially Stacy, as the community voice, brings that clinical and community perspective to her communications with people in our state Medicaid program. As a side note to all of this, what has been happening all along the way is that local advocates have had to learn this new language of pharmacy formularies and the pharmacy and therapeutics and the drug utilization review board, all of these mechanisms that are in place for figuring out what drugs get covered by state insurance. None of us really understood this process before we had to learn this new language for hepatitis C and to be able to advocate successfully for treatment. So to anyone feeling kind of overwhelmed in this by all the acronyms and by this labyrinth of processes, please know that it's learnable and that I think all of us who are advocating on this issue have had to teach ourselves this and learn from each other. And that's why it's really great to be part of NVHR's treatment access group, because I think along the way we've all helped each other understand these things and learned things we never even wanted to know that none of us really, I think, had an understanding of maybe 2 years ago. And to that end, we've been inspired by being part of this national network, and especially over the last year, watching how states have really stepped up their response and taken different advocacy approaches to expand treatment access. So Legal action is certainly something on the table. It was great to see New York State's Attorney General get involved. In Pennsylvania, it was harder for us because we had a scandal in our Attorney General's office. Some of you may have seen there was just a federal indictment, and so she had to step down, and so that was not going to be a route that we would take because Hep C treatment was not that agency's priority. There have been some individual lawsuits filed, so that helped bring some local publicity to the issue. And then I think the Abu Jamal advocates have done a great job in trying to bring attention to treatment access in jails. And we've been trying to up our protest game. We were especially inspired by New York, and I know Matt will talk more about their approach after us. And watching their video of seeing vocal members storming a meeting and protesting really inspired us to team up with our local ACT UP chapter and pay a visit to our decision makers in Harrisburg. So on the next slide, you'll see some pictures from our caravan that we took to the Pharmacy and Therapeutics Committee meeting in May. We had about, it's hard because it's in Mechanicsburg, so that's about a 2 to 3 hour drive from Philadelphia. So going up there is really an all-day affair. So it can be hard to get a team of folks who are willing to make that road trip and go up and then sit through a really boring meeting in a room with a bunch of people wearing suits to protest. So we got about a dozen folks up. We had 5 partners that we recruited to give testimony in front of the committee. So that included some clinicians and advocates as well as an attorney from Harvard. And then the next slide, you can see the protesters that we had holding up signs. So it was a silent protest. We waited for the P&T Committee to make their decision. If they voted not to expand treatment, then we plan to protest. But while they deliberated, they were surrounded by these advocates holding up signs. And I think it made a really powerful statement, and it's not something that ever happens at these types of meetings. Stacey, I don't know if you want to elaborate.
Sure. I'll say that there were members of the P&T Committee that really commented on the fact that that meeting was unlike any that they have had in the last 2 decades, and really reminded them of why they were all in the room and what was important to see the faces of patients and advocates really noting that their decision affected hundreds and thousands of individuals and their lives and the lives of their loved ones. And so if any of you out there are thinking about doing something like this, I really do encourage you to consider it. You want to consider the environment, consider what's going to be most powerful, and I think especially in those meetings where they don't necessarily always make the connection that their decisions have a direct impact on healthcare decisions for others in a very, very meaningful and profound way. It's great to be able to bring folks in to show them that they're being watched and the decisions they make really matter. I do just kind of want to mention that the reason why we had to go to Harrisburg and Mechanicsburg for this is because this is where the state Medicaid P&T Committee meets. Now, in Pennsylvania, state Medicaid really only covers about 10% of patients on Medicaid, but at least in Pennsylvania, we know that no managed care Medicaid program can be more restrictive than the state fee-for-service program. So we knew that if we could make a difference at the state Medicaid fee-for-service level, that then all of the other Medicaid programs from managed care organizations would have to follow suit. And so when you're thinking about taking limited resources and the voices of your advocates, you want to make sure that you get the most bang for your buck. And so rather than going to the 10 managed care programs and trying to duplicate this over and over again, we really target our effort to fee-for-service, because we knew that whatever was decided there will eventually trickle down and be enforced with the managed care organization. Next slide. So that day was a great day. it was on May 17th, and the P&T Committee did vote to remove all fibrosis score requirements for fee-for-service coverage. And unfortunately, after the extraordinary jubilance of that day, in the last 3 months, there has been silence from DHS, and we're still waiting on Secretary Ted Dallas to sign off on the P&T Committee's recommendations from that day. Patients continue to be denied treatment based on their F score, and you know, there have been a community of patients that have really become frustrated with this and have sort of catalyzed what may end up being legal action if, in fact, a decision is not made in favor of the P&T Committee's recommendations in a more timely manner. Next.
So what next? And I think this is part of the challenge of what we're all trying to do, is that we're often moving in slow steps and piecemeal while we wait for one group to make a decision that will kind of determine our next move. So do you want to talk about our legal partnership?
Yeah, sure. So I think the other role that HepCap has really played, not only to be a clearinghouse and a place where we make connections for individuals living with hepatitis C, for providers with other providers, but also for patients who may be frustrated, but also for lawyers who maybe are dealing with a challenging case and wanted to connect with other lawyers who are working on similar issue. But really, HepCap is a connector of people, and so we have tried to play that role and have really been successful in connecting legal partners with each other. And we find that, I'm sure most of you know, hepatitis C is underfunded and resources are limited, and so what we try to do is take the limited resources we have and multiply them by bringing them together and creating synergistic relationships between folks. And certainly the folks with legal backgrounds have been one part of what we do, but also the same thing applies to community-based organizations, clinicians, and patients.
So in thinking about how you can look at what we've been doing in Philly and thinking about what you might be able to do in your own jurisdiction, here some of our lessons learned would be this. So one, I think learning from others is key. We could not have gotten as far as we have without being part of a broader national conversation. And I think NVHR has done a great job convening people both through the email listserv and through calls like this, but also by providing resources online on their website that everyone can borrow from. And I think speaks to how great this community is to share their resources and materials and let other people copy and paste and cut and paste things to use. So use NVHR, use this network, look at success stories, look at what happened in other states, and think about what models that have been done or activities that have been done might work in your own state. And we're a friendly bunch of folks, so you can email us, you can pick up the phone and call us. I think anyone who's managed to succeed in pushing treatment access forward is happy to share our experience. So, you know, we looked at what happened in New York. We couldn't go the Attorney General route because of the scandals I mentioned in our AG's office, but we could do a protest, and we could go to a P&T committee meeting, and we could send people up. Ours was maybe not as lively as the New York protest, but it got attention, and in a conservative state like Pennsylvania, it made a really big impact in putting people's faces in front of that committee. And I think that Harvard Law, their health program, has been a key partner, not just for us in Pennsylvania, but across the state. They've been really great in lending their legal authority to this issue and giving a lot of us advocates on the ground with some strategies to consider and talking points to consider. Next slide. So learn as you go. So this goes back to my point that we all have this new language, these new sets of formularies and whatnot to learn. So learn what the process is in your state. Meet stakeholders in government and in policymaking and advocacy who can help you understand it better. You know, things have maybe become more contentious with HepCap in the state since we've protested on their doorstep, but we do still have a way to get in touch with them and communicate with them, even if they're maybe not responding to our emails so fast anymore. But don't be afraid to introduce yourself as an advocate to folks at the state level. And I think one way we were able to do that in the beginning is offering ourselves as resources and saying we don't want to work against you, we want to work with you. How can we work together to access? Because at the end of the day, I do think folks at the state level want to see everyone get treated, but they have a budget that they're concerned about. And so how can we work together to move the needle forward? Don't get discouraged if it gets overwhelming, because it is overwhelming. And I know that for me, it's made me even more furious with our healthcare system in this country. It's amazing to me, like, how many backdoor ways there are decisions without really thinking about the community. And I wish it was a more transparent process of how drug pricing and drug formularies are decided upon. But I think that we've seen that come more to light and become a conversation with politics, and it's been in the media. And so I think this is a time for us as advocates to really capitalize on some of these broader conversations around drug access in general. And relationships are really key in getting anywhere. And so I think, like Stacey said, that's been a real strength of our coalition, is to build relationships and try not to be adversarial when possible, try to use a friendly approach, and then kind of gear it up as we need to. And so I think that goes to the next slide, which is Plan A, B, and C. So we've been polite, and now it's kind of stopped working for us. So you find out the meeting schedules of the P&T Committee and the Drug Utilization Review Board. Sometimes they only happen a few times a year. Sometimes if you want to speak at these meetings, you have to put your name on the agenda a month in advance. So find out what those logistics and details are. Do you have to RSVP? Are these public meetings? If you're going to bring in a group of people, how are you going to get them up there? We brought members of the press with us, invited members of the media. And I think remembering to follow up if you do have an action, keep following up on keep people engaged. And we're always thinking of what new partners we need to bring to the table. And I think it's important to think about what help we need from federal partners. It would be great to see them be more vocal on this issue of treatment access. And obviously more funding and more resources is something we could all benefit from. Hepatitis remains really tragically underfunded and under-resourced. And on the next slide, I put a quote that I saw once on a gas station sign, and I've seen since on shirts and other things. Well-behaved women seldom make history. And I think that we aroused in the hepatitis community to the degree that we saw in AIDS activism and ACT UP in the early days. And I think some of us aren't as comfortable with protesting and being loud. But, you know, I raise this as our kind of final point, and maybe something to bring up in a discussion at the end. Patients continue to be denied access. So is it time for us to take a louder approach? And what does that look like? And what other tactics can we try if our polite protocol isn't working? And I think we have some ideas of what that might look like, but I would love for that to be part of the conversation at the end with the broader group on this call. And I think that actually ties really nicely into ending our segment and moving into New York's experience. I think there's a few more slides that have contact info on there, but we're done. To the Health Federation, who's our principal sponsor of HepCap.
Thank you both. Fantastic work you're doing. Our next presenter is Matt Curtis, who will speak about work in New York State. Matt Curtis is the Policy Director of Local New York, a grassroots membership organization that works to build power among low-income people affected by the war on drugs, HIV, hepatitis, homelessness, and mass incarceration. Directs vocal support and policy advocacy with a particular focus on health disparities, drug policy, and criminal justice reform. And I know Matt can tell you he is definitely a man with a mission. Matt, I'm turning it over to you.
Okay, thanks for. I'll just kind of chime in with some more love that was reflected at the beginning of the meeting, because I get the pleasure of being able to work with Ronnie often on, and in fact she's one of a really small number of people that you know, initiated a lot of the stuff that is happening today, and you know, along with people like George Santana and Sherry Foster and others. And a lot of the stuff that I'm going to talk about today just wouldn't look like it does now without folks like Ronnie and those other folks early on. And then I'm also a North Wilmington, Delaware native, so I've got a special love for Philadelphia, and it's been really great seeing what you guys have been doing down. So let's jump in. Next slide. So briefly, I mean, you know, overall, a lot of the stuff, the kind of major themes or the kind of environment, both epidemiologically and politically, and in terms of public health policy that we're dealing with in New York, looks a lot like the things that were described for Philly and Pennsylvania. But very briefly, we have at least 250,000 New Yorkers statewide are thought to be living with chronic hep C. That number is probably a bit higher than that. It's relatively evenly split between New York City and the rest of the state. There's about 60% maybe in New York City. And just by comparison, that looks a little bit differently than the HIV epidemic here, which is much more overwhelmingly situated in the 5 boroughs. We don't have an estimate of incidence, but we have increasing access to testing, in part because of a law that was passed a few years ago that I'll talk about in a bit. But in just the past year, we had nearly 15,000 new positive screens reported from the labs. We still seem to be doing a not great job in getting confirmatory testing happening for everybody. So, you know, but nonetheless, that is a pretty alarming number. I mean, of course, some of those folks are people that have been infected for many years, but because of a bunch of other things happening, we suspect that we do have pretty steep and increasing incidence in recent years. Again, by comparison to HIV, we had well under 3,000 new HIV infections in 2015, so it is radically different in the way it looks right now. Some of that other stuff, you know, like much of the rest of the country, we are seeing a resurgence of injection drug use, particularly heroin use, and now, unfortunately, homemade fentanyl or non-pharmaceutical fentanyl products being put into heroin and sold as heroin. That, you know, and we're seeing, like, if you kind of look at maps of new diagnoses, particularly in New York City, it correlates very closely, although not perfectly, with, say, overdose mortality and stuff like that. So we're seeing a really close relationship between those things. Statewide, it's kind of all over the place. We have really wide variation in all aspects of the care system around hepatitis C, from access to preventive services, especially harm reduction, which is sort of concentrated in some places and very unavailable in other places, including places where we're seeing new injection drug use and new hepatitis C outbreaks, to testing care, treatment infrastructure. You know, half the state population-wise is spread across a really big geographic area, a lot of which is rural or not particularly close to bigger towns where you might find ready access to testing, linkage to care, and actually getting treatment. And then as our Pennsylvania colleagues described, the treatment access is beginning to open up, but we are really seeing a lot of barriers. I'll get into that in a little more detail also. Next slide. So first, I'm just going to go really quickly through kind of what's happened in the last 3.5 years or so, because I think that's the period where advocacy from organizations and the kind of policy environment has really started to shift. Obviously, that is in part related to the introduction of the new curative therapies, which kind of galvanized people a lot more. But here's the rundown, and then I want to highlight kind of a few key elements that have been involved in the campaign work from the community and the community government partnership side here, and then sort of come back again to where we're at now, what we're looking to do in the near future, and some immediate challenges that we're still facing, or kind of heaviest on our minds maybe. So kind of going to more like the beginning of 2013, there really started to be kind of, I'd say there's a number of organizations here that work on hepatitis C and have done so for years. We also have a very large AIDS service organization and AIDS activist scene in New York City, and there's outstanding ASOs in a number of other places around New York State. And I think those groups really started paying a lot more attention to Hep C, partly because we were starting to get more traction around HIV. There was more attention to co-infection, and just a little more of an environment that was facilitating some of that work to be focused on Hep C in a more sustained and pushy and bigger way. So beginning of 2013, when the sort of discussion at the national level was happening around cohort-based testing, was sort of getting resolved a bit. An elected official from upstate New York, whose father actually had passed away from hepatitis C, introduced legislation to basically replicate the new CDC cohort-based testing guidance as a requirement to mandate a testing offer. So our organization got behind that, as well as a number of other groups, and ultimately we passed that, and it became law in I think September 2013. It became the first testing law in the United States, and kind of inspired some similar action elsewhere. From that, around that time, we started seeing the Sovaldi and the other first DEAs being introduced, and along with both the immediate astronomical nosebleed level pricing and the restrictions that were being put up by payers, a bunch of groups started coming together on an ad hoc basis to both target Gilead and other manufacturers through activism. And so, we did a pretty long series of actions at investor conferences and other meetings, kind of going after them, helping kind of drive that negative media attention. You may have noticed that we did not get them to try and eliminate price barriers to access, but I think it's nonetheless been important to keep that piece of the conversation happening. And we also started, kind of beginning to learn more ourselves, much in a way that the Pennsylvania presentation described, and engage with our state Medicaid system, figure out, kind of how this was playing out on a policy level with private insurers, public insurers, and begin advocating together for more action to open up treatment access, as well as more action with our state government to increase funding. As a result of that experience, at the beginning of 2015, those organizations came together and formed a new statewide advocacy coalition called the New York State Hepatitis C Coalition. There's a screenshot of our homepage. It's hepcnewyork.org. Down at the bottom there, there are now 25 organizations involved, And we previously had other groups kind of doing stuff in coalition. So New York City Department of Health and Mental Hygiene, for example, has long helped operate a New York City Hepatitis C task force that has representation in each of the boroughs and kind of separate meetings in each of the boroughs. We wanted something a little more specifically focused on policy advocacy, and rather than a vehicle for sharing clinical experience or kind of networking providers or something like that. So, have been the beneficiaries in New York State of, like Pennsylvania, an enhanced surveillance grant from CDC, which allows us to do a little bit, but honestly, it's not that much money. And the New York City Department of Health got a $10 million grant last year to implement a multi-site kind of treatment excellence program to basically prove the concept that we can do it cost effectively, and that we can increase treatment capacity and sort of build it outside of the sort of specialist care that was providing the previous generation of treatment. Around that time also, the coalition had begun engaging in a few ways with both our office healthcare unit and some private legal advocacy groups to kind of raise the issue of treatment restrictions and start kind of pushing them to take a look at this. So at that time, on the Medicaid side, our Medicaid program at the end of the last year had decided to basically put fibrosis score restrictions in line with what had been happening elsewhere in the country, and a number of other things, some of which were not as problematic as in some other states. So for example, we still have some language in our treatment guidance in our fee-for-service treatment guidance on drug and alcohol use, but it's much, much milder than in a lot of other places. It's something we still need to clean up, but it's not sort of a formal barrier. It's sort of a guidance for clinicians to kind of take account of things that may impede people's adherence. We think that's still a very bad idea that's not supported by clinical medical experience, but it hasn't been the same that it's been in places like Illinois or Oregon or whatever. Ultimately, we, through a series of kind of pushing through activism, negotiating with our state Medicaid program on policy, doing things like taking over our drug review utilization board meeting, and having people really be consistently participating over a number of months, working, to kind of push the story through the media, getting legislators involved, getting the New York State Attorney General started a suit against private insurers, while private groups were on the verge of launching a suit against our state Medicaid program, which I think was sort of only secret to the extent that it wasn't widely public, but folks knew it was coming. Ultimately, earlier this year, in April, the Drug Utilization Review Board voted to remove fibrosis restrictions for fee-for-service altogether. At the same time, they added a number of the other newer direct-acting antivirals to the preferred part of the formulary. So all the major anti-Hep C medications are preferred now. And at the same time, the Attorney General was able to settle with a group of pretty much all of the major private insurance companies. So that was pretty great news. A couple other recent things. We've also seen a kind of steady increase in New York City Council funding for hepatitis B and C programming. Since the establishment of a new fund in 2014, that amount of money has roughly doubled. It's still not humongous, but it's a really good sign, and it's allowing some really important things to happen. We have not yet seen an increase in funding at the state level. And then right now what's happening is the launch of a new effort to actually push toward an elimination strategy akin to what we've started to do in New York State around AIDS. Next slide, please. So how have we gotten here? There's been a bunch of different things that have happened. I'll talk a little bit about maybe more about what my organization Vocal does, but I want to stress that nothing that happened, like no victory we have ever had around any of this stuff in New York State has not involved a lot of coalition. That that advice that you were getting from Alex and Stacy at the end of the last presentation about the importance of coalition building, educating advocates or professional advocates, and creating that kind of broad space for people to engage on the issue is incredibly important, and maybe the best takeaway possible from any of the stuff we're talking about today. One thing that my organization does that relatively few others do is we are a community organizing based group. We're a membership organization. We're a membership led organization. So that means that we go out and engage low-income people living with Hep C and facing other issues that we deal with. And they are the folks that set the direction of our campaigns. They are 100% of our board of directors that governs the organization, that approves all staff hiring. And just sort of in our bones as an organization generally, but I think we just authentically believe, in part because of our long history of working on HIV/AIDS, that we are not going to solve the problems related to the Hep C epidemic unless there is authentic leadership and input and ideas from directly affected people. One thing that and there are other groups certainly that mobilize folks living with Hep C. Housing Works does quite a lot of that. There are patient groups like Ronnie's excellent organization, or COPE, or other groups in New York State. I think that's something, it's hard to do, but in some cases, if you don't have the infrastructure for it organizationally, but it's something that I'd kind of encourage people to think about. How do you create that leadership and develop that leadership around the epidemic in other places? I kind of mentioned coalition building already. That's just been crucial. It's something that's still a work in progress, but I think has a lot of potential, particularly around New York. One other thing we've been pretty blessed with here is that from the get-go, even as much as different pieces of our city and state government are targets of our advocacy, we've had really strong partnership from the viral hepatitis folks at the New York City Department of Health and similarly at the New York State AIDS Institute, which covers, in addition to AIDS, viral hepatitis and drug user health and LGBTQ health. And that's been, pretty amazing because it's sort of, there's sort of limits to our ability to kind of collaborate in all things. We can't be sort of taking money from them to lobby the government or, sort of giving them too much of a heads up about some of our activism. But it's been a really good partnership that's sort of given us a lot more information than we might have had without it, and has just sort of allowed us to play not only an outside game, but an inside game more often than we might otherwise be able to. We have a thing that is developed over a number of years called the Plan to End AIDS by 2020, which is a long story, but it is a commitment endorsed by our governor and funded to some extent and backed with a number of administrative and legislative changes that have happened. And that also has a very important Hep C frame to it that I'll get into a little bit more in a second. And then, as I said, we have, unlike Pennsylvania, had a little bit more of an opportunity to engage with our attorney, which was really, pretty immediately receptive to, sort of addressing some of the problems they were seeing. If you're in a place where you feel like you can't deal with your AG's office on this, or they just don't feel like it's a priority for them. I would say, you know, we are at a stage nationally where any insurance provider who is restricting access to hepatitis C treatment does not have a leg to stand on in court. And, you know, I think they honestly all know that, and they're doing all kinds of things to, you know, sort of protect themselves from having to do that. You know, everything from straight up restrictions that are formal to insane prior authorization procedures to stalling to all kinds of other stuff. But, you know, if you can at least engage with legal advocacy groups like defender organizations and so on, often those folks will take up at least individual cases and get turned, or potentially, you know, develop a class action suit or another, you know, bigger suit that actually changes policy. Last word on this part, I'd say, you know, we've put a fair amount of energy into not only sort of just doing simple stuff like putting out press releases when big stuff happens, but really developing relationships with health reporters and other, you know, other media who are interested in this issue, you know, kind of business side around, you know, the many billions of dollars that pharma is making off of the epidemic, to the kind of human element of the treatment restrictions or the debates around it in government, and making sure that, you know, media are educated, they're getting fed stories, we're giving them people who can really tell their own personal story about how treatment restrictions or other aspects of sort of problematic public policy around Hep C have affected them. So again, that's just sort of another thing to think about that allows us often to amplify our voice and kind of gain public attention and move elected officials in particular ways that we couldn't absent that kind of commitment to public communication through the mass media. Next slide. So I'm going to start trying to wind down so we leave a little bit of time for discussion, but really quickly, I talked about already the picture you see here is actually the Vocal and Housing Works test we did. We actually did more than one at our Drug Utilization Review Board. This was, I guess, a little bit, this was last fall, so not the actual event where they changed the restrictions, although we were there for that also. And, you know, from our organization, you know, most of our staff are community organizers. We are fortunate to have a dedicated statewide community organizer dedicated to hepatitis C, who has been building a base of directly affected people, primarily in New York City, because that's where we are, and it's a little bit easier to do it here. There's more venues for it. But we've also been doing this kind of town hall series that has focused on bringing in both directly affected people, patients, people who use drugs, people at risk of Hep C, and providers and local public. Other folks in the state, we've done 4 primary ones already in New York City, Albany, Syracuse, and Buffalo, although we've done repeats in a couple of those places. We've got another one coming up again in Syracuse this month. And, you know, from our perspective, at least as far as our organization goes, nothing we do on this, whether it's lobbying for more budget resources with elected officials, or showing up to the Drug Utilization Review Board, or going to coalition meetings or whatever, is done without the direct involvement of people living with Hep C or have been cured of Hep C. Next slide. You know, I'll mostly skip this one, but just again to say, you know, if you look it up, you can just easily Google this. You know, there's a number of sections of this that are focused on Hep C co-infection. There's a number of other policy proposals that are contained in the blueprint, again, which was endorsed by our governor, which, you know, include everything from expanded access to harm reduction to, you know, I don't think Governor Cuomo is fully cognizant of this, but we managed to slip in a recommendation to create supervised injection facilities as one means of preventing HIV and hepatitis C. I'm proud of that in particular. And there's sort of a bunch of stuff in here that could be useful as a model, and I think New York has gotten, as imperfect as a project this is, I think New York's gotten some deserved notoriety for pushing this. It was a huge coalition effort. It really got the full buy-in of our state and New York City governments, and there's a lot to learn from it here. And also, I think it's been a big vehicle for us being able to advance some progress on Hep C. Next slide. Again, briefly, the cultivating government partnership, and I think for most people on the call, that's going to be first and foremost with your health departments is really crucial. They can be great allies, both for us information we need and can't otherwise get, and sometimes they're really, really helpful and do that in sneaky ways. And they can also do a lot of internal advocacy. One thing that, and I think one thing clearly that's led to in New York is funding from both agencies to support some of the advocacy, education, research, and an emerging program that I will talk about now in the next slide. So last big thing on what's happening now. Early this year, the coalition that's been working on this started convening a series of meetings with our health departments to talk about how do we get toward an elimination strategy that the state can endorse. And again, this is really modeled on, like many of the organizations, very closely involved in the ending the AIDS epidemic effort. So really closely modeled on that in a lot of ways. And basically, to make a long story short, we have kind of reached the point where there is agreement from all parties about the kind of basic strategy we're starting with. We are at this moment in the process of populating 5 sort of expert working groups, one on prevention, another on testing and linkage to care, one on treatment access, one on data surveillance and metrics, and one on social determinants of hepatitis-related health. And we are basically moving toward a summit meeting in January that's going to be sort of politically focused and aiming to bring sort of a whole bunch of recommendations, data, and a political push to get us at least closer toward much more visionary and comprehensive action on Hep C. And next is the last slide. So, last thing, not to make it sound rosy in any way, there's a lot of problems we're really facing. I've talked about some of this stuff already. But, one, I'd say for all of our work, going back probably 10 years to when Ronnie and other people started initially doing Hep C legislative awareness days up in Albany, we still have pretty low public and political awareness given the scale of the epidemic here. And we kind of struggle to figure out how to punch through that, but we have not done it yet. Despite the second, I'd say despite the change in the fee-for-service Medicaid guidance and the settlement on the private insurance side with the AG, a lot of pretty nefarious behavior by individual Medicaid managed care programs. I'm less certain about the private side, but still we are seeing people struggle to get access, and we're seeing a lot of people get access to treatment, but it is not smooth sailing by any means yet. Part of that still is, while we think that the other manufacturers have been increasing their discounts steadily and kind of negotiating in reasonably good faith, Gilead has really not even been at the table, from our understanding. Prices have come down. Anybody that says anybody's paying $1,000 for a pill is wrong everywhere in the country at this point, unless they're buying it straight from Gilead for some crazy reason. But nonetheless, that's given just the efficacy of Harvoni and the fact need that as a first-line medication, it's still been pretty difficult. the limited state investment is still an issue despite some new money for some of the advocacy and kind of convening stuff. The state invests a total of $1.17 million for a state with 20 million people and 250,000 plus people with chronic Hep C into the viral hepatitis unit at our State Department of Health. So that is not even in the same universe as resources for HIV, let alone any sort of reasonable estimate of what we could need to deal with Hep C. I alluded earlier to the fact that we have a sort of new generation of injection drug users in New York. They don't necessarily reside in places where there are access to harm reduction programs. There's also, not many programs that do a great job of serving young people who inject drugs. And so that's a kind of particular challenge that we're dealing with on the prevention side. And then, as I said in the very beginning, we've got overall weak infrastructure in all parts of the thing. And this is, even in a state with, I think that has some of the best ID public health infrastructure of any place in the country. And that's all I've got to say. Thank you very much.
Thank you, Matt. I just want to make two comments because we're getting short on time. Matt's right. We've come a long way since 2006 when we all first, there were 5 of us that went up to Legislative Day, but we still have a lot of work to do. And I urge coalition members that they draw from all communities to carry this message effectively. One more thing I want to add, and then we'll go into some questions. The Attorney General here in New York the healthcare unit has suggested that patients call into their helpline with complaints, especially around the Medicaid managed care programs. The New York number here, which will be displayed at the end and in the slides, but I'm going to give it to you now. I urge please make a call. It can be a medical provider for your patient or the patient themselves. It is 1-800-428-9071. This way the Attorney General's office will look and start an external review. So we need this to be done. There are some questions that we have for both Pennsylvania and New York. I want to start out with just one question from me because I get this all the time from patients. Patients to this community as a patient, they've never been exposed to legislation. How do we prepare these patients? How can we get them to be involved? So anybody, that question?
You guys want to go first?
Yeah, so I think our meetings are open to anyone, and I think for our trip to Harrisburg, we invited everyone. I think, again, sometimes the challenge is being mindful of the time it's going to take out of people's day, and I think we could do a better job trying to engage patients, and I think that's something we've been wondering about internally as a coalition because we want to see that group more representative. It's a really important voice to have. That we try to be as open as we can, but I do think we could be more proactive of figuring out where to go to bring patients in. I think our collaboration with our syringe exchange program, Prevention Point, they've been really great in helping us engage patients from their population and from the community at risk. And they will bring folks along to our meetings, and they brought folks to our trip to Harrisburg. And so I think it's some things we consider as like having meetings out in the community, going out and seeking out those patients more. So as a coalition leader, I think that's something that we wonder about. I don't know that we have all the answers to it. But we're always, I think, mindful of needing to do a better job with patient engagement.
Yeah, I mean, here at Vocal, we kind of do this every day. So, and it's really a straight up old-fashioned community organizing strategy. So we go out and find people at risk of living with have been cured of Hep C. And in New York City, and elsewhere, we primarily do that through service providers because it's a pretty efficient way to find people. So what that looks like is we first obviously build relationships with service providers. That here includes our 14 syringe exchange programs. Local is actually one of those. Hepatitis C, clinical care providers, a bunch of other kinds of settings. And we go out and do teach-ins as a first thing and just go and basically set up times and talk to people, patients or people otherwise affected by Hep C, about their experience, talk to them about what's going on, explain sort of our model and how we engage around this, educate people about the policy stuff, kind of using a popular education model, about the epidemiology behind this, about the things that are preventing them from getting the care or treatment that they need, and basically helping then develop relationships with people one-on-one where we kind of figure out people's self-interest for getting involved and then immediately give them an opportunity to do something. So when we meet somebody for the first time in any setting, if we can get their contact information, they will get within 3 days at latest. And during that call, they will get invited to participate in something, whether that's an upcoming meeting or an action or a rally or whatever kind of else happens to be going on. And part of that also is for each of our organizing campaigns, we have what we call leadership, a subset of our members who are most engaged. It's self-selecting, so people are basically show up if they want to, and that's where we sort of develop strategy and tactics for our campaigns and sort of do more of that leadership development to get people in a position that when they get stuck in front of a reporter or a state senator or whatever, they're well informed and they can make kind of both good decisions about being involved at all, choosing, sort of deciding how we want to approach stuff, and actually be able and prepared to reflect their own experience as it relates directly to the policy questions at hand.
Great, thank you. Matt, while I have you, a question came in that I need to get an answer for. When, month, and year did New York State overturn the fibrosis restrictions in fee-for-service, and have any of these changes translated over to managed care organizations?
Yes, I have the Drug Utilization Review Board meeting summary open on my desktop, and it was April 27, 2016. And then the question was, has this resulted in changes at the MCOs?
Yes. Translate.
Yeah, it has, although we have 18 Medicaid managed care organizations in New York State, plus some HIV/AIDS special needs plans that also, serve people with Hep C. So it is a whole lot to keep track of, and I think what we've seen is that what we've been hearing from legal advocates that have continued to kind of serve people and help deal with denials and stuff like that is that there are some that have kind of swiftly moved in the right direction. So I'll say end of April was the meeting where the DIRB overturned the previous fibrosis restrictions. It was about 1 month later that our health commissioner certified that. So it's been, let's say, June 1st, so it hasn't been a super long time. But, and basically we're hearing kind of a mixed bag. And, I think generally what we're hearing now, and Ronnie may know more, is that, nobody's really doing straight up fibrosis denials anymore, but they are putting up other barriers that either dissuade, slow down, or kind of, otherwise, create hurdles to people actually getting treatment. And I think it's, it varies quite a bit between the MCOs, but we don't honestly, because there's so many and nobody sort of has a great read on, the health department does not have a centralized kind of database on like what all the policies are at the moment or anything like that. Do you know any more, Ron?
The only thing I know is that certain MCOs are being asked to get a letter of adherence signed.
Yeah, so they're kind of reverting to some of the other.
Went away and just replaced it with another.
Yeah.
Yeah, okay. We have time probably for one more question. Tina, did you have something you wanted to add, someone that burned?
Sure. We have a couple questions from the audience, and any that we receive and don't have a chance to ask, we will send to the panelists and try to include summary. So I guess one of the last questions I'll ask is if any of the speakers can comment on efforts to train more providers, given the limitations on the GI community, particularly not having enough providers in public sector organizations. And so how is it or New York?
Sure, I can try to talk a little bit about that. We through HEPCAP have started a program called HCV for PCPs, and we're planning on executing 2 modules. The first module is really just basic, how to get providers to test and refer appropriately, but we're in the process of putting together a second module for practices that are able to successfully accomplish first module, and that really is to create an ongoing mentor-like relationship, sort of like an ECHO model, but for an urban community where we can get folks online and ready to treat.
And we've done that by integrating it into our education and training center. So they're already well experienced in managing logistics like CME and scheduling and doing needs assessments with providers. So it was a really natural fit. And our fiscal sponsor, Health Federation, also happens to be the Philadelphia performance site for our Mid-Atlantic AIDS Education and Training Center. So it's a really nice partnership that we have with them. And they do a lot of the legwork, and we have asked all of our clinical partners to, they've all said they would give like an hour, they'd be willing to do an hour presentation a month. So we have a lot of folks we can call on to go out and do those.
Great, thanks.
I have nothing smart. I have nothing smart to add to that. That was good.
We also had a question, we only have a couple minutes, but if any of you have done any work with private health insurance to expand access?
I mean, we've at Vocal have overwhelmingly focused on Medicaid because that's who insures our members. So no.
And Alex or Stacy?
Yeah, so most of my patient population has been the Medicaid population. We have had pretty good luck with private payers in the state and definitely within the city to relatively open access, which has actually been helpful in making the case with Medicaid as well. I'm sure that there have been some challenges, and we try to learn about those through HEPCAP and sharing of ideas at our meetings. But we haven't really had to direct very specific advocacy work towards private payers.
Well, this is Tina Broder from NVHR, and I want to thank all of our panelists and our participants for being involved in the webinar today. A reminder, be sending out a copy of the recording and the slides to everyone who registered, and we will also be posting that information on our website. And I encourage everyone to get in touch if they have additional questions and to visit NVHR's website, dedicated section with resources on treatment access that we continue to add to. And for those who are not already a member, please go to our website and join NVHR to stay in touch with action alerts and other webinars. And if anyone has questions or comments, they can go ahead and email me at pbroder@nvhr.org. Thank you all for your participation today, and have a great weekend.
Thank you. Thank you.